Am I audible?
Yes, you are audible. Yes.
Good morning. Good morning, sir. Good morning, respected faculties and my seniors. Today's topic is nutrition in surgical patients. Assessment of nutrition. Okay. There is a spectrum of nutrition status in surgery patients. They could be underfed or overfed. For this, we assess nutritionally through anthropometry, body weight, clinical history, body composition analysis, serum markers, fluid and electrolytes, and indirect calorimetry. Anthropometry measures body height, weight, and proportion with respect to the same age and gender. We can measure it through skin fold thickness, mid-arm circumference, head to chest ratio, and hip waist ratio. Body weight is important for fluid resuscitation and monitoring patients' nutrition. Ideal body weight we can calculate in male and female differently, separately. In males, we take 50 kgs plus 2.3 kg for every 2.54 centimeter above 152 centimeter. In females, we take 45 kg plus 2.3 kg for every 2.5 centimeter above 152 centimeter height. But the drawback is it's limited to only patients with who are more than 5 feet tall, and it underestimates the body weight in female. In obese patients, we can measure adjusted body weight calculated as ideal body weight plus 0.4 multiplier current body weight minus ideal body weight. Lean body mass, non-adipose, it represents the non-adipose tissue mass. Sacropenic obesity represents a low lean body mass despite generous fat stored. In such patients, there is high risk of post-op complications and malnutrition. Body mass index, weight, it is measured as weight in kg divided by height square in meters. Less than 5th percentile is underweight and more than 95th percentile is obese. Normally, normal person BMI is 18.5 to 24.9 kgs per meter square. Less than 16.5 to 18.4 is underweight and less than 16.5 is severely underweight. 25 to 29.9 kg per meter square is overweight, and in obesity, more than 30 is obesity, with obesity grading being grade 1 being 30 to 35.9, grade 2 35 to 39.9, and grade 3 more than 40. Clinical history of the patient. Malnutrition. We should assess the malnutrition status by asking the patient if they have poor food intake or starvation. It could be due to poverty or the geographic location or previous GI surgeries. 30% of GI surgeries can result in malnutrition, and 60% approx patients have malnutrition who have delayed hospital stay due to the post-op complications. Malnutrition can also be due to disease or injury or malnutrition. Malnutrition can be a protein deficiency or a micronutrient or caloric deficit. In acute cases, we can see pitting edema, sunken eyes, poor skin turgor. Chronic cases has Kwashiorkor signs and growth stunting. In Kwashiorkor sign, we can see the dark scaly skin of the patient, protruded belly, and brownish hair. Malabsorption, it should be classified as congenital or the cause is pathological. Comorbidities, if there is any metabolic disorders, and if the patient is drug or alcoholic dependent. Body composition analysis. We can do it by DEXA dual energy X-ray absorptiometry for bone and soft tissue measurement. HRCT. HRCT is highly useful, but drawback is high. It has high cost and high radiation exposure, and patient needs to be transported. USG, it can be used bedside. Benefit is it's easily available, easy to use, low cost. Individual muscles can be measured. Drawback is it's operator dependent. Serum markers. Albumin, pre-albumin, transferrin, retinol binding proteins, these can be used to preoperatively to assess nutritional status. Albumin forms more than 50% of the protein of serum. Its half-life is 20 days, so it can indicate the chronic nutritional status. It is a negative acute phase reactant. It is used to predict post-op mortality and morbidity. If preoperative albumin is less than 3 gram per deciliter, then it indicates high risk of complications within 30 days of the surgery. Less than 2 gram per deciliter pre-op albumin measures 30% of mortality risk. And it is an unreliable marker for nutritional assessment because it remains normal even after until there is severe malnutrition. The BMI drops down to less than 12, or there is a 6 weeks of starvation. There is decrease in inflammation. Albumin decreases in inflammation though patient is adequately not nourished. So it cannot be used as a reliable marker. Pre-albumin has half-life of 2 days and it reflects recent nutritional status. It is also negative acute phase reactant. That means it decreases in inflammation. Transferrin half-life is 8 to 9 days. Retinol binding protein. Fluid and electrolytes. There is average daily water balance we can calculate as normal output is urine, feces, skin, and lung. Urine and feces is obligatory, and skin and lung is insensible losses. Urine is 1500 ml per day, approx 100 ml per day through feces, and approx 900 ml per day insensible loss occurs through skin and lung. Normally we take from beverages and water 200 ml of water per day. Through food we take 1000 ml, and through fat oxidation we take 300 ml of water. 300 ml water balance. Daily electrolyte, we require sodium as 50 to 90 millimoles per day, potassium 50 millimoles, calcium 5, and magnesium 1 millimoles per day. We should determine the nature and type of fluid replacement therapy required in the patient. Like if patient is having diarrhea or vomiting, if the cause is burn or sepsis, there is replacement fluid to correct pre-existing deficiencies, and the supplemental fluid is used to supplement if we are anticipating there is going to be intestinal loss or other losses. Indirect calorimetry. It's the gold standard to estimate nutritional needs. That is resting energy, expenditure, or basal metabolic rate. It is used to assess the amount of heat generated indirectly according to the amount and pattern of substrate used and the byproducts generated. Like substrate in presence of oxygen generates heat, carbon dioxide, and water, and this is used to estimate the nutritional status of the patient. If we don't have the indirect calorimetry, or we cannot do that, then we can go for Harris-Benedict equation. It's a bit complicated. In males, this is calculated as 66 plus 6.24 into weight in pounds plus 12.7 into height in inches minus 6.7 into age. This formula is little bit complicated. In female, basal metabolic rate is 655 plus 4.35 into weight in pounds plus 4.7 into height minus 4.7 into age. So we have to measure the patient's weight, height, and age. And these parameters are used to calculate the Harris-Benedict, basal metabolic rate. Now, monitoring feeding regimes, body weight, fluid balance, CBC, fasting blood sugar, serum sodium, potassium, urea creat, urine output, and temperature. These should be measured daily. Urine and plasma osmolality, plasma protein, especially albumin, LFT, including clotting factors, triglycerides, acid-base status, calcium, magnesium, zinc, phosphate. They should be measured weekly. Vitamin B12 status, iron, folate, lactate, and trace elements like copper, manganese, they should be measured fortnightly, 15 days. Nutritional assessment scores. There are 4 to 5 screening scores to assess nutrition, like nutritional risk screening, Nutric score, the MUST tool, and the Perioperative nutrition screen. Nutritional risk screening. In this, we measure the impaired nutritional status and the severity of the disease. For every normal, if the patient is normal nutritional status, then we score it 0. If there is a weight loss of more than 5% in 3 months, or the patient is taking less than 50 to 75% of the normal daily food intake of the preceding week, then we categorize as mild and scoring it 1. If the weight loss is more than 5% in 2 months, or if BMI is 18.5 to 20.5, plus there is a general condition of the patient is impaired, or the patient food intake has decreased to less than 60%, 25 to 60%, then the score is 2. If the patient has more than 5% weight loss in 1 month, or more than 15% weight loss in 3 months, or the BMI is less than 18.5, plus there is impaired general condition, the food intake has decreased to less than 25%, then it is a severe, categorized as severe impaired nutritional status, and we mark it as 3. The severity of the disease depends on the type. If the patient is normal, then score 0. In case of hip fracture, chronic patients with acute complications, COPD, diabetes, chronic hemodialysis, oncology patients, 1 score. Major abdominal surgeries, stroke, severe pneumonia, hepatomegaly, or malignancy, moderate status, score 2. Head injury, bone marrow transplantation, and ICU patients with Apache score more than 10, then severity, it's severe, and score is 3. We calculate both, add the both impaired nutritional status score and the severity of the disease. And if the patient age is more than 70, then we add 1 to the total score, and we call it as age adjusted total score. Nutric score stands for nutrition assessment in critically ill patients. The parameters are age, Apache 2 score, SOFA score, comorbidities if the patients have days from hospital to ICU admission. Usually interleukin 6 is not taken into account. In that case, the total score is, if 0 to 4, then low, categorized as low malnutrition risk. And if there is more than 5, then it is high malnutrition risk. And if we are taking interleukin 6 in the account, then if the value is more than 400 for interleukin 6, then we add 1, and the total score gets 0. If up to 5 is low malnutrition risk, more than 6 to 9 is high malnutrition risk, and we need to plan nutrition. The patient needs the nutritional plan. The MUST tool, it's a 5-step screening tool to identify adults who are malnourished or at risk of malnutrition. We take into account 3 factors: BMI of the patient, unplanned weight loss in the past 3 to 6 months, and if the patient is acutely ill or there has been a nutritional intake of less nutritional intake in past 5 days, then we score it 2. We add the all 3 scores. If the score is 0, then it's low risk. Score 1 case may medium risk, and then more than 2 or more than 2 score is high risk. Perioperative nutrition screen. This is used to optimize the pre-operative nutritional status of the patient. It's again a 3-step process. Step 1, BMI we take into account. BMI is less than 18.5, or if the patient age is more than 65, then BMI taken is less than 20. Step 2, weight loss score. If there has been a weight loss of more than 10% in past 6 months, or in step 3 we take if the patient has been eating less than 50% of the normal diet previously patient was taking. If there is yes to any of the step 1, 2 or 3 points, or the serum albumin level is less than 3, then we need to optimize the patient preoperatively, and we need dietitian intervention and nutritional assessment. Criteria to initiate perioperative nutritional support. Now, if the patient has past history of severe undernutrition, or there is chronic disease, if the patient has a weight loss of more than 5% in 1 month, or more than 10 to 15% in last 3 to 6 months, if we are expecting a blood loss of more than 500 ml during surgery, patient has BMI less than 18.5, or there has been a or the patient's weight is less than 20% of the ideal body weight, serum albumin level is less than 3, transferrin level less than 200, on the growth curve there is failure to thrive. We can see that by if the patient has less than 5th percentile growth, or the patient's growth curve is crossing 2 major percentile. If we are anticipating that patient will not meet the caloric requirement within 7 to 10 days of the surgery, or there is catabolic disease, burn, sepsis, trauma, pancreatitis, in these patients we should initiate perioperatively nutritional support. Thank you.
Very well presented, Dr. Aditi. You have covered almost everything, but certain things I want to excuse me, point out.
Yes, sir.
When you are talking about the various scores or parameters, you mentioned which are specific for the pediatric age group. Like in anthropometry,
yes,
skin fold thickness, go to the next slide, skin fold thickness and
head circumference
ratio can be used for adults, but mid-arm circumference, head chest ratio, these are more specific for the pediatric age group. So you mentioned that. Okay. Then there is a simple ideal body weight formula, that is weight in kg minus 100 in centimeters. So that you have to keep in mind, because that is a very easy working formula. These things are very difficult to remember, this formula. Later on in one of the slides, you have talked about failure to thrive and the growth curve. That is also specific for the child population. Next.
Yes.
You have talked about sarcopenic. The term is sarcopenic. It's not sacropenic. Okay.
Yes, sir. Sorry, sir.
Sarcopenic.
Yes,
and
sir.
Where you have talked about this BMI less than 5th percentile and more than 95th percentile, what is the commonly used notation for this, or what is the commonly used? What do we mean by 5th percentile? Median value minus 2 standard deviations. If the body mass index is below this, then underweight, and median value plus 2 standard deviations. If weight is above that, if BMI is above that, then you say it is more than 95th percentile. This is an important correlation, because 5th percentile does not give you a working idea as to how to calculate it. So you must know the parameter that is used for calculation. Where you have mentioned the serum markers, you have mentioned almost all. One more very important marker is transthyretin. You should not forget. When you have described the intake from beverage, it should be 2000 ml, I think. From fluids and beverage, it's not 200, it's 2000 ml. So correct this in your PPT.
Yes, sir. Yes, sir.
And where you have talked about indirect calorimetry, can you tell me? There's heat plus carbon dioxide and water formation. Yes. You have said. Yes. What is this heat released in the form of what? This heat is released in the form of what? ATPs. So it is because of cellular oxidation of phosphorylation. Yes. Yes. And when you have talked about the BMR in women, it should not be 655. It's 65.51. Okay.
Yes, sir.
It should be 65.51. All the nutritional scores and all you have described very well. Thank you for this wonderful presentation.
Yeah. And another thing is, Aditi, as you start for nutritional assessment, you have taken first the assessment criteria and then gone to the history. So it should be better that you talk of the history part of the assessment first and then go for clinical assessment and then the biochemical assessment. So that are the standard steps. And in surgical patient, particularly nutritional deficiency occurs particularly in patients who has got intracutaneous fistulas, patient having short gut syndrome. These are more important in surgical patients. Okay. And then as you have talked of Harris-Benedict equation, that is a basic energy expenditure. In surgical patient, you have to take into account the stress. There is a stress factor which is multiplied with basic energy expenditure to get the calorie required for a particular person. Okay. So because a burns, patient has a catabolic stress, patient needs major surgery, patient is intracutaneous fistula. So in that case, that basic energy expenditure should be multiplied by that metabolic factor. And once you talk of this pre-op assessment, you have given the simplified way of selecting patients. You go to the pre-op assessment, you say. So these are the basic steps. But patient who are having this albumin being low and then patient is filling the criteria that patient needs malnutrition, you have to go to the whole list of assessment again and plan your management. And always keep in mind the albumin is a marker for chronic malnutrition. Patient having acute malnutrition, albumin may not be a marker. So albumin low means patient has global nutritional deficit. So it's not that albumin low means he gives an albumin transfusion. So it should be a global malnutrition. Okay. Otherwise, you have presented very well. Good.
Thank you, sir.
So next we pass on to assessing the nutritional requirement in surgical patient. That will be by Dr. Uma Murmu, who is a first-year junior resident at SSKM Hospital. Dr. Murmu, you can share your screen and start presenting. Dr. Uma, you can unmute and share screen. Yeah.
Hello.
Yes, yes.
Good morning, sir.
Yeah, please start.
I am presenting nutrition requirements in surgical patients. The goal of nutrition support in the surgical patient is to prevent or reverse the catabolic effect of disease or injury, to meet the energy requirements for essential metabolic processes and tissue repair, to meet the substrate requirements for protein synthesis. First, we have to estimate the energy requirements of the patients. So we will assess our pre-surgical patients by history of weight loss, chronic illness, dietary habits of the patient, social habits of the patient, use of any medications which influence the food intake or urination of the patient, physical examination of the patient by weight, BMI, skin fold thickness, arm circumference, muscle area, and we can do biochemical test, creatinine excretion, albumin level of the patient, pre-albumin level of the patient, total lymphocyte count, and transferrin level. Now, caloric requirement in different conditions. Like in normal individual or in moderate stress, the per day kilocalorie requirement is 25 to 30, and protein requirement is 1. In mild stress, it's 25 to 30 kilocalorie per kg per day, and protein requirement is 1.2 gram of protein per kg per day. In moderate stress, it's 30 kilocalorie per kg per day and 1.5 gram protein per kg per day. In severe stress, 30 to 35 kilocalorie per kg per day, and protein requirement is 2.2 gram of protein per kg per day. In burn cases, the energy requirement 35 to 40 kilocalorie per day per kg per day, and protein requirement become 2.5 gram per kg per day. Now, macronutrient requirements. We have carbohydrate, protein, fat, as we know. In carbohydrate, glucose is the preferred carbohydrate source. The obligatory glucose requirement is 2 gram per kg per day to meet the need of the CNS and hematopoietic cells. Basal requirement of the glucose is 100 to 200 gram per day. Now, protein to support the nitrogen balance. Basic requirement for nitrogen without pre-existing malnutrition and without metabolic stress is 0.1 to 0.15 gram per kg per day. In hypermetabolic patients, it increases to 0.2 to 0.25 gram per kg per day. Now, fat. There are 4 long-chain fatty acids, 2 saturated and 2 unsaturated. A small amount of linoleic acid, a medium-chain fatty acid, are also contained in our diet. Provision of only 1 liter emulsion of UFA per week avoids the deficiency. And provision of fat as soybean oil based in emulsion on a regular basis, it will obviate the risk of essential fatty acid deficiency. Energy during parenteral nutrition should be given as a mixture of fat together with the glucose. And basal requirement of essential fatty acids is 100 to 200 grams per week. Now comes to micronutrients, vitamin and minerals. Water-soluble vitamins like B and C for collagen formation and for better wound healing. Post-operative requirement for vitamin C increases to 60 to 80 milligram per day. Supplemental vitamin B12 often indicates in patients with intestinal resection or gastric surgeries. Absorption of fat-soluble vitamins A, D, E, and K reduced in patients with steatorrhea and absence of bile. So we need to supplement them as well. Now, micronutrients like sodium, potassium, phosphate, magnesium, zinc, iron, biotin, calcium, copper, selenium, and these we need to supplement to our patients, especially in patients on long-term parenteral nutrition. Now we have our routes of administration. First, enteral nutrition, enteral route, which is the most preferred and best by mouth, or we have tube feeding techniques in which nasogastric tube or Riles tube, feeding fine bore feeding tube, gastrostomy, surgical or percutaneous or fluoroscopic, nasojejunal tube, jejunostomy, maybe surgical, direct percutaneous, endoscopic or fluoroscopic. And in the parenteral nutrition, we have peripheral access and the central line. Now, enteral nutrition, which can be achieved with normal food, oral supplements, or with variety of tube feeding techniques, delivering food into stomach or duodenum and jejunum. Initiate as soon as feasible after adequate resuscitation, and in setting of gastroparesis, feeding should be administered distal to the pylorus. Current recommendations support early enteral nutrition within 48 hours with early caloric limitations, and the goal is to provide more than 80% of the estimated total energy gradually by 3 to 4 days. Early enteral feeding also associated with reduced incidence of fistula formation, and concomitant gastric decompression with distal small bowel feeding may be appreciated in certain patients like head injury patients and with gastroparesis. Hypocaloric nutrition is currently recommended for critically ill patients, especially during the early acute period of critical illness. Now, we have some complications of enteral nutrition as well, like tube-related malposition, displacement of the tube, blockage of the tube, breakage, leakage of the tube, and local complications like erosions of the skin or mucosa. Now, GI complications, like diarrhea, bloating, nausea, vomiting, abdominal cramps, aspiration, and constipation. Metabolic and biochemical complications like electrolyte disorders, vitamin, mineral, trace elements deficiency, and drug interactions. Infective complications, exogenous by handling hand contamination, or endogenous. Now, parenteral and nutrition. Indication are malnutrition, sepsis.
I think Uma, the next speaker will speak on parenteral nutrition. We can discuss this part. Okay. Parenteral nutrition taken by the next speaker. Dr. Didiman, you can discuss about the nutritional requirements she talked of. There is something more to be touched on.
I would like you to go back to the slide where you have discussed about carbohydrate, protein, and fat requirements. That's important. Actually, the carbohydrate requirement is not calculated in absolute weight terms as you have described.
Yeah.
What we say is the the total energy requirement is fixed. Suppose 25 to 35 kilocalorie for the patient. No, I'm saying for that particular patient, suppose a patient is 50 kgs and the ideal weight is 50 kgs and the patient caloric requirement for that particular patient is 30. So the total caloric requirement is 1500. Okay.
Yes.
Now that particular patient, suppose the patient requires 1.5 gram per kg of protein. That is fixed. So this 1.5 gram per kg means he needs 50 kg patient, so he needs 75 grams of protein daily. Now, 75 grams of protein will give into 4 because 1 gram gives 4 calories, 4 kilocalories. So he will get 300 kilocalories from proteins. Now it is recommended by the global goals of good nutrition that 10 to 20% should of the energy should come from fat, not more than that. So if the caloric requirement is 1500 and I assume that okay, for that particular patient, the patient is not in need of hypocaloric nutrition, the patient needs about 20% fat, then again 300 kilocalories will be coming from fat because the total is 1500, 20% means 300. So 300 is coming from protein, 300 is coming from fat. Rest 900 grams, 900 kilocalories should come from carbohydrates. And each gram again gives 4 or 4.1 kilocalories. So you divide 900 by 4, that comes to something like 225. So that is how the calculation comes for carbohydrate. Carbohydrate is never recommended as a fixed weight like you said 100 to 200 grams per day. It is not recommended like that. The calculation is coming to that only. But in different patients with different protein and fat requirements, the carbohydrate requirement gets adjusted to meet the total caloric need. Now, somewhere you have mentioned hypocaloric nutrition.
Again, Didiman, in this point, when you calculate, again, the same formula comes. Once you are trying to calculate the total amount of calorie, again, you have to calculate the basal energy expenditure plus the metabolic factor. Next is you find some recommendations that when you calculate the total amount of calorie, you allocate 7 to 80% of this calorie to come from carbohydrate and 20 to 30% should come from fat. The amount of calorie you calculate from the protein should not be taken into account the calorie required for this particular person, because protein is, suppose a surgical patient, here protein is given for your own healing, for fighting the stress. So you may not take into account the amount of calories. Suppose you get 50 grams of protein, that gives you about 200 kilocalorie. So these 200 kilocalorie of energy from the protein should not be subtracted from the total amount of calorie you are giving from fat or protein. So protein should be kept reserved for bodybuilding rather than that being used for calorie requirement. So that is one point you keep in mind. The total calorie required is divided between the carbohydrate and fats. And protein should be kept reserved for bodybuilding. We will not exhaust that protein for calorie requirement. That is one. Second is when you talk of requirement of nutrient, it would have important that you see the nutrient required from oral to IV are different. So if you talk of nutritional requirement in oral form, you can take complex carbohydrates. But when you come to the parenteral preparations, there are some parenteral preparations. How do you supply carbohydrate in parenteral feed? It is either 10% dextrose or even 25% dextrose. How do you deliver fat in parenteral nutrition? That comes at glycerol, that comes at fatty acids. Okay, how do you supply protein in nutritional supplements? It can be either amino acids or peptides. Okay, so the nutritional items are different from oral and parenteral groups. So these are things you should be having a knowledge that what you are supplying by parenteral bottles. You have 10% fat emulsion. You have 20% fat emulsions. You have 10% human albumin. You have 25% human albumin. You have amino acid infusion. And these food items are available each in separate bottles. And now you have the liberty of using a pre-mixed bag, which delivers you about 1000 to 1500 kilocalorie if you transpose 1.5 liters. Okay, so that is a bag having, some bags are having 2 chambers, which you mix just before starting the infusion. So these are important to know what are the components available in the market to be given as parenteral nutrition. And oral nutrition is it. Oral nutrition is what you take daily. That can be, you see, there are some food items which are known as elemental foods. The food item you talk of like Ensure or Resource, whatever is in the market, they supply you a combination of things which need not be digested. These are all simple food in powder forms that you can give either as a oral feed or given as an enteral feed. And these food get absorbed before terminal ileum. So if you have intravenous fistula, these are the food you can give, which are not being having a residue to go to the terminal ileum. Okay, so these are the nutritional items that can be used in our surgical practice. And then comes the way of nutritional therapy. Okay, anything else, Dr. Mitra?
The protein requirements values you have given, I think you have divided them by 10. Go back to the protein requirements.
Yes, sir.
It should not be 0.1 to go to the next slide. You have written 0.1 to 0.15. Okay, that is the basic requirement.
That is a multiplication.
Okay, that is nitrogen. Okay.
Multiplication.
And
the protein requirement depends on the stress. The previous slide you mentioned, normal situation, 1 gram per kg body weight. Stress, depending on the degree of stress, the protein will increase. And again, I'm saying that this protein is not for caloric calculation. This protein is for bodybuilding.
And when you are talking about burns, for burns, there is a separate curative formula. You can use that, which takes into account both the percentage of burn and the body weight of the patient. So please read that formula for caloric requirements in burn patients. And when you say hypocaloric nutrition, it is generally for brain injury, head injury patients where we do not want to give them much fat, because fat is a calorie-rich substance. 1 gram gives 9.3 kilocalories. So you have to keep the patient dependent more on non-fat nutrition.
Non-fat nutrition.
And regarding the routes of nutrition, enteral nutrition, you could have given a comparison between gastrostomy and jejunostomy. That would have enhanced the presentation. Otherwise, you have mentioned about all the routes. Different types of feeding jejunostomies can also be asked in the question. Witzel technique, the different techniques of it, Witzel technique, stamp technique. Okay. And I think that should be okay.
Okay. So the last presentation is by Dr. Sudipto Mukherjee. He's a first year junior resident at Apollo Hospitals. So he will speak on the different routes of nutritional supplements. Already Aditi has talked of Uma has talked of the enteral nutrition, so you can skip that part with a brief introduction. Do you share your screen?
Yes. Good morning, faculties. I'm Dr. Shudipta Mukherjee. Hello.
Yes, you're audible.
Yes, sir. Sir, I'm presenting nutrition in surgical patients, mode of nutrition in enteral and parenteral forms. Nutrition, enteral and parenteral form. Nutritional administration. It is found that in surgical patients, it becomes a matter of concern to determine when, how, and what to feed them. Open abdominal surgeries produces a paralytic ileus of various length that alters the digestion, absorption, and nutrition of the patient. And the ileus generally resolves after generally 72 hours, which is marked by passing of flatus. And it is found that our small intestine begin to function after 1 hour of surgery, and stomach within 48 hours. Colon typically starts working after 72 hours. Factors improving GI recovery following abdominal surgeries include laparoscopic surgeries. In laparoscopic surgeries, the bowel handling are less, so it is less traumatic, and it is associated with short period of ileus with respect to open surgeries. Epidural analgesias, they causes less dependency on narcotics for pain control, thus limiting their side effects. Enhanced recovery after surgery is a multimodal perioperative care pathway that makes us make use of perioperative counseling, early enteral feed, use of peripherally acting mu receptor opiates, standardized analgesic and anesthetic use, early mobilization of the patient with major surgery. It has been found to reduce the number of hospital stays up to 2.5 days and lesser post-operative complications. Route of administration. Oral route of administration of nutrition is preferred as it is physiological and less invasive. Patients with altered mental alertness and orientation are at increased risk of aspiration and should not be being oral nutritional regime. Patients who have undergone strokes or pharyngeal surgeries may have difficulty in swallowing. They are to be considered for modified oral diet, such as mechanical or soft diets. Diet selection. Clear liquid diets, mostly in form of sugar and water, usually after an acute illness or after surgery when they are intolerant to food. Also given to prepare the bowel for surgery and GI procedures. Clear liquid diets provide 700 to 1000 kilocalorie per day, which includes tea, coffee, juice, and carbonated beverages. Full liquid diet, it includes food that are liquid at body temperature. It provides 1200 kilocalories of energy with 40 grams of protein per day. Regular diet, which is unrestricted diet to meet caloric, protein, and elemental needs of the body. Nutritional support. The patients are to be assessed for the preoperative and postoperatively for nutritional support to withstand the catabolic stress. Most patients of elective surgery have adequate fuel to withstand the catabolic stress for 7 days and are not benefited from perioperative nutritional support. For these patients, IV fluid, appropriate electrolytes, and minimum 100 gram of glucose per day is adequate to sustain their catabolic stress. However, well-nourished patient can become malnourished after surgery or trauma without nutritional intervention. Without proper nutrition, their immune functions is impaired. Without wound healing becomes poor and high risk of post-operative complications. Now, routes of nutritional support. Enteral route. It is indicated for patients having functional gastrointestinal tract but are Enteral nutrition is preferred over parenteral because it is physiological, it maintains mucosal integrity, and cytoarchitecture of the intestinal tract.
You to show your screen. Screen is not visible.
Okay, sorry.
Yeah.
Roots of nutritional support. Enteral. It is enteral route. It is indicated for patients having functional gastrointestinal tract but are unable to sustain adequate oral diet. Enteral nutrition is preferred over parenteral because it is physiological. It maintains mucosal integrity and cytoarchitecture. It keeps normal absorptive function and keeps the gut flora alive. Contraindications, sir, 1 second.
Go up.
Yes. Contraindications in enteral route is intestinal obstruction, upper GI bleed, severe diarrhea, intractable vomiting, and severe inflammatory bowel disease. The forms of enteral route, we can use feeding tube like nasogastric tube, nasoduodenal, and nasojejunal, gastrostomy tube. Jejunostomy tubes are available. Enteral feeding products, commercially available various enteral formulas depending on the disease, such as renal, hepatic, diabetic.
Sudhita, you are not audible. You can see the screen, but you are not audible.
Network.
Okay, I think he's logged out and coming back. Okay.
Network might be.
Yes, some network issues. He has a lot of spelling mistakes. He's not bothered about every slide has got a lot of spelling mistakes. That is not desirable. Very poor English.
Parenteral spelling is wrong.
Yes, every time he's writing enteral. And a lot of spelling mistake other places also. We are trying to contact him. Just wait. Uma, you are online? Uma? Dr. Uma, can you hear us?
Yes, sir.
I think if Sudipta cannot log in, you have some part of parenteral nutrition in your slides, no?
Yes, sir.
Just a minute. No, you can ask Uma to continue with the parental part. Uma, you can share your screen and continue the remaining part of the parental nutrition time to talk. Now Uma has stopped at that point. Share your screen and talk a little part of parental nutrition from your side. Yeah.
Yes. So parental nutrition indications are malnutrition, sepsis, surgical or traumatic injury in seriously ill patients for whom use of GI tract is not possible that time. Can also be used to supplement enteral nutrition after 1 week of use if use of enteral nutrition is unable to meet more than 60% of energy and protein requirements. In parenteral nutrition, the TPN given by right subclavian line, central line, 2 liter volume transfused for 24 hours, in which amino acids are 4.5%, dextrose 17.5%, lipids 20%, and 99 gram of protein. And this overall will provide around 2,275 kilocalories. Now, complications of parenteral nutrition related to nutrient deficiencies: hypoglycemia, hypocalcemia, hypophosphatemia, hypomagnesemia, or refeeding syndrome. Basically refeeding syndrome and chronic deficiency syndrome related to overfeeding, hyperglycemia, hepatic steatosis, fluid retention, electrolyte abnormalities, related to sepsis, catheter-related sepsis, related to line on insertion, pneumothorax, air embolism, cardiac perforation, tamponade, pleural effusion, hydromediastinum. In long-term use, occlusion and venous thrombosis. Nutritional supports in refeeding syndrome. It's a potentially fatal condition which occur in patients who have experienced prolonged period of starvation. Before initiating nutritional support in them, we have to check electrolyte abnormalities and deficiencies and must be determined and corrected. High potency B vitamins and daily B vitamin supplementation is recommended, and feeding at 10 kilocalories per kg per day over 4 to 7 days to be done. Nutritional support in inflammatory bowel.
Closer to the microphone. Sound is little less.
Okay. Nutritional support in inflammatory bowel disease and short bowel syndrome. The basic strategy is to restoring healthy gut microbiome with dietary changes, probiotic, prebiotic, diet with high protein, low fat, low carbohydrate, diet with low sucrose, low refined carbohydrate, and omega-6, and high in fruits and vegetables. Nutritional support in patients with EC fistula, TPN is preferred. Exception is if fistula is located in distal bowel or has low output, that is less than 200 ml per day. Enteral nutrition can be attempted with monitoring in fistula output, and supplement with antibiotics. Nutritional support in bariatric patients, if adjustable gastric band, then iron supplements to be given. If sleeve gastrectomy, then vitamin B12 supplementation to be given. And in Roux-en-Y gastric bypass, iron, vitamin D, copper, and calcium supplements and multivitamin supplements need to be given in them. That's it, sir. Thank you.
Okay. Regarding the nutritional therapy, Dr. Didima, you can have some discussions. The part Dr. Mukherjee has spoken.
Yes. Yes, talked about the various routes of enteral nutrition. That is fine. Enteral nutrition. Why enteral nutrition is to be used wherever possible. That has been emphasized. The problem with Shudipta's slides were that they were too crowded and too much information was there, and a lot of spelling mistakes. But that can be corrected. And regarding TPN, the monitoring is very important as to what parameters have to be monitored twice daily. What has
and before that, Didiman, he has made a statement that in post-op period, 7 days is the time when patient can maintain his nutritional reserve. That is not a correct statement.
No.
The statement should be patients who are nutritionally preserved pre-op can withstand the catabolic stress for 3 to 5 days. Beyond 5 days, you have to consider nutritional support. 7 days, a blank statement is not acceptable. Patients who are nutritionally borderline, they might need nutritional support immediately after the surgery, maybe about 24 to 48 hours. So that all depends on what patient you are taking up for surgery. If the patient nutritionally preserved pre-op, he can withstand for 3 to 5 days of catabolic stress. If the patient is already compromised, nutritional support should be thought of early. That is one part. Yes, Dr. Didiman.
We must emphasize from practical point of view also, we must emphasize creation of enteral routes of feeding as much as possible. Like I will share my experience this week only in our ward. There was this patient with giant gastric perforation. Our residents repaired it with the omental patch, but next day in rounds I'm seeing that there is about 500 ml bile in the drain. And I asked them whether they have done a feeding jejunostomy. They haven't. But since there was 500 ml bile, we thought of re-exploring the patient as early as possible, so as to mitigate have a relook. The patient was taken up in the emergency again. During surgery, they could not identify any other source of bile, so they closed the patient. And again, in spite of opening up the patient second time, they forgot to do a feeding jejunostomy. So we must emphasize that feeding jejunostomy should be created whenever possible, because parenteral nutrition this option is there, but it can never replace enteral nutrition in whichever patient we can give it. Parenteral nutrition should not be considered as superior to enteral nutrition.
Yes.
The reasons for that have been discussed by Dr. Mukherjee. And regarding parenteral nutrition, there are some preparations which are meant for peripheral lines. They are called TNA, peri, etc. So we have to be very careful that the formulations which are made for peripheral application should not be used in central. The other way around can be used, but it should not be done. And regarding the monitoring as to how frequently you should monitor for what electrolytes. And clinically also you have to be vigilant whether the patient, suppose the patient starts developing jaundice, parenteral nutrition. You have to keep in mind that maybe this patient is having this because of parenteral nutrition. Thank you, sir.
Yeah. So any other comment, Madam? Dr. Boshak?
No, sir, Makunda, it was good. Just the spelling mistakes were very eye-soaring.
Eye-catching. It was eye-catching.
So otherwise, the topic was good. And the first girl, she spoke very nicely, giving all details about...
Yes, nutritional assessment, yes. Because these are important. You see, this nutritional assessment will come in your long case assessment. This can be a ward round scenario. We have a ward round scenario this month to discuss post-op nutrition management. So all these points will come. When you give a scenario of nutrition surgical patient, again, all these points will come up. How will you assess nutritional status, how to plan therapy, and what are the indications, how do you calculate the calorie requirements. So we have discussed about the basic aspect of nutrition management surgical patients. Thank you all.
Diabetic patients যদি parenteral nutrition use করছে so you should know these things. In diabetic patients, when you are using parenteral nutrition, you should neutralizing the formulation.
So you have to think of the nutritional requirements also, and also you have to cover the dextrose part with sliding scale of insulin, so that patient doesn't go into hyperglycemia. Okay. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir.
क्या भाई क्या प्रॉब्लम हो रहा है सर्जन